Welcome, national audience. This is Scott Dugas with the Hospital Preparedness Program, and I'm here. We're representing this call for the division here, the Division of National Healthcare Preparedness Programs, managed by Dr. David Marcosi, and we're going to jump into this call on rural healthcare issues and IBA. We're happy to have this call. It's one in a series of national calls that we've done over the past year, and we encourage a lot of participation. We look forward to a robust discussion. We have an expert panel set up for you today to walk through some of these challenging issues with rural coalition development and thinking through the concepts of immediate bed availability and our healthcare capabilities that we promote through our national guidance. With me also is Ms. Tracy Pohl, the Region 8 Field Project Officer here with HPP, and she's going to assist. Tracy's going to walk through our speakers and a little bit about what they're going to talk with you about, and then afterwards we're going to close with a question and answer session. And we're really excited about this spirited call. We know that healthcare coalition development is a challenging topic. We've been promoting it for a number of years here along with the rest of our, and embedded in our capabilities. And doing that in rural and frontier areas, building coalitions, has its own unique set of challenges and problems attached to it. We know this is going to be the first in a series of national calls that we want to have on this topic, and we want to start the discussion. And this is a great forum to do that, and we're excited again. So with that, I'm going to turn the call over to Ms. Tracy Pohl and let her walk through a little bit more of the agenda in detail. Tracy?
Great. Thanks so much, Scott, and good morning, good afternoon to all of the folks that were able to join us on this call. As Scott mentioned, my name is Tracy Pohl. I'm the Field Project Officer located out in the Region 8 Denver office and work closely with the folks back at headquarters. In my role, I have the great honor of working with the great states of Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. And actually a great majority of our regional conversations look at how we conduct business given the rural nature of our region. So on behalf of Dr. Lori, Don Boyce, and obviously Dr. Marcosi, we're delighted to welcome everybody to the first rural preparedness call out of our office, and as Scott mentioned, hopefully one of many, and equally delighted to showcase some of the excellent stories and resources for others to consider as they look at their planning and response roles in a rural environment. In addition to our great speakers today, I publicly would like to recognize North Dakota, Virginia, West Virginia, Michigan, New Hampshire, and Utah, and anyone else who I may have missed who actually offered to speak on rural successes as well. But given our 90-minute platform, we have to call on each of them for another time, hopefully keeping these conversations and their successes in the spotlight as we continue to learn from one another. Lastly, a special thanks to the other project officers who helped all of us coordinate and organize this call. It's been an exciting 6 months. We think it's incredibly important to note that we have a diverse group of partners participating on our national call today, including, but certainly not limited, to our partners from CMS, from HRSA, from CDC, from IHS, from Department of Homeland Security, Department of Transportation, our state offices of rural health, our community health centers, our long-term care partners, our state offices of EMS, of course our ASPR team both at headquarters and in the region, of course, our state and local health departments, and ASCO and HO partners, hospitals, local emergency management agencies, I guess just to name a few. As our program continues to support healthcare coalition development, it's critical that the right people are at the table. So a few things we'd like to ask of all of you listening in or participating via web before we get started. Please send questions anytime in the web chat if you are logged in online. We'll queue these up at the end and do our best to answer each question during the question and answer period. Any questions we don't get to, we will include them in the meeting summary. Secondly, please check out our materials, the slides, including the recorded sessions today, all of the resources discussed, and the questions and answers will be included on our hospital preparedness website following the call. Lastly, I listened to a webinar recently where connectivity was the key for how rural facilities could respond to an event more successfully. So please consider exchanging electronic business card and connecting with somebody from this call at another time. At this point, I would like to take this opportunity to introduce a dynamic group of presenters and hope during this call you'll hear different approaches on how to maximize healthcare organizations' participation in a rural setting, how rural planning efforts have supported responses, and one approach in developing a strong healthcare coalition in a rural setting. We'll kick off with Dr. William Mason, who's the principal investigator for the Arkansas Department of Health. Today, he's going to walk us through a rural response that occurred in the southwest corner of Arkansas, and he'll share how this disaster led to some new partnerships and some new policy changes across his state. Our next presenter will be Ms. Jean Randolph, a nurse consultant at CDC, the Center for Disease Control, working with the hospital preparedness activity. Ms. Randolph is going to speak about the community assessment tool, its utility, and how this tool can help bring people together in a rural setting. Ms. Randolph's overview of the tool will lead into our next presentation from Randy Bolts. Mr. Bolts is the safety coordinator at the Howard County Medical Center, a critical access hospital in St. Paul, Nebraska. He's going to share his strategy for implementing the community assessment tool in his small community and how this tool has helped him to date with planning and partner engagement. Following Mr. Bolts' presentation, we'll hear from Ms. Leslie Schulte, the Public Health Emergency Response Planner for Andrew, Atchison, Harrison, Holt, and Tri-County Health Departments, all in Missouri. Ms. Schulte is a co-lead for the Region H Healthcare Emergency Preparedness Coalition in Missouri and is going to walk us through the Healthcare Coalition development process in her rural area of that state. Lastly, but certainly not least, we're going to hear from Mr. Jay Taylor, the Acting Director with the Pennsylvania Department of Health, Amanda Krebs, the EMS System Coordinator for the Susquehanna Emergency Health Services Council, and Stan Hudson, the Emergency Preparedness Coordinator at the Evangelical Community Hospital in Lewisburg, Pennsylvania. These presenters are going to close our call today by discussing a recent Greyhound bus mass casualty incident that took place in rural Pennsylvania and discuss how this region responded together to address medical surge and bed availability. So, without further ado, I'd like to get started with Dr. Mason. Thanks very much. Dr. Mason?
Thank you. Today I'm going to discuss something that happened in a very rural area in Arkansas and what policy changes we made coming out of this tragedy. This is the Albert Pike flood. Albert Pike is was a very popular campground for residents coming out of Louisiana, Arkansas, and Texas. As you can see on this first slide, children, parents could wade in this very clear stream that's coming out of the Ouachita Mountains and camp in this area overnight. Now, going down to the Albert Pike campground is like, I've really never seen anything like it in Arkansas till this tragedy occurred. You go down into almost a very narrow canyon, only one road leading in and out, and the area itself is extremely narrow. And so you can see why families are attracted to this, very shallow water, clear water, and many during the peak summer months, hundreds of families come here and stay overnight. So I'd like to go to the next slide and click on this video where our governor, Governor Beebe, describes what happened in the early morning hours of June the 11th, 2010.
A different kind of devastation than I've ever seen. It frankly boggles the mind how swift that water was. There are 4-inch, 4.5-inch slabs of asphalt that have been ripped up and forced under other asphalt, moved out of the way. I saw a tractor-trailer truck wrapped around a tree. That's the kind of stuff you expect from an F4 and F5 tornado. That's how powerful that water was. Cars that are turned upside down, campers turned upside down. 2 o'clock in the morning, 2 a.m., the river is about 3 to 3.5 feet. By 5:30, it was 23 feet high. That's roughly a 20-foot increase in just a matter of a couple of 3 hours. I mean, that's a lot of water in a hurry. I don't know how these people would have known. They're asleep, first of all. Most of them at 2 or 3 o'clock even if there'd have been, if they'd had a radio or something that they could have tuned to, odds are they were asleep at 2 or 3 o'clock in the morning. It was really, really the worst possible time for people to be able to protect themselves. I think the folks that have lived here all their lives have indicated that they've seen floods before, but they've never seen anything like this. So I don't know if anybody can imagine what those people were going through. You don't see many major disasters with that much loss of life. This was obviously people like to camp out. They like to camp out in wilderness areas. They like to camp out by rivers. They like to camp out in areas where they can get away. All of those things, I think, worked in this instance to create a horrific, horrible outcome for so many people and so many families.
Thank you. So next slide, please. So what this describes, what you initially saw is the campground, the pristine campground as these campers saw it the day of about the day of before the flood, and that at 2:30 in the morning, due to heavy rains, the Little Missouri River rose 20 feet in a matter of minutes. These people were trapped. Even the children who tried to get to some of the rest areas in some of the restrooms were trapped as the restrooms were totally flooded. And so there were 20 people dead, very few people. There were actually no hospitalizations except for a few scratches. People went to the ER for a few scratches. And so people were either alive or... So there was no hospital surge that was tested on this capability. Now, this remote area, when I went down into this area on the day of the flood, there was no cell service, obviously. Satellite phones did not work. There was no way to communicate deep in this canyon. And these people, as was mentioned, there was no early warning system in place to alert these campers of this flood. They were totally trapped. So next slide, please. So what HPP capabilities were tested? I'm just going to talk about 2, but I'm going to go into the fatality management in a little bit of detail and tell you what we learned in Arkansas. The 2 primary things that were tested were fatality management and information sharing. Next slide, please. The information sharing, we had something called Arkansas Wireless Information Network radios, which communicated through all agencies through these handheld radios, and we could communicate not deep in the canyon, but as we came out of it, we could communicate with various other individuals and state agencies. Now, the problem with that is when we were talking about individuals who were being recovered, that is, the victims who were being recovered, anyone could listen into this. And so what we did is we went to the state legislature, and then we have between around 12 secure channels for use for health only. So the one thing we learned from this for communication was we need secure communications, secure health communications for our AWINS radios. We had to go through the legislature to get this, and we do have some secure communications for any future significant health tragedies or disasters where we got to have a secure radio network that others can't listen in on. We also have redundant communications with our ham radios, AWINS that I've mentioned, sat phones, and our cell phones. We've got our amateur radios or ham radios set up in almost all of our hospitals in the state of Arkansas, so that if everything goes down, we still have ham radio capabilities. Now, so we look at our communications, we want redundant communications. But one thing we did learn is in a canyon this deep, in something this deep, there is no really way that you can communicate, that we found that we could communicate, and that's going to be always a problem in some of these rural areas. Now, next slide, please. Now, about 2 weeks before this happened, we had been struggling in Arkansas with how do we manage mass fatalities? Do we contract with a refrigerated truck, people who drive refrigerated trucks, companies that have refrigerated trucks to store bodies? We couldn't quite figure it out until we came across through one of our coroners here at Pulaski County who did contract work for a company called Kenyon International. We talked with Kenyon International. They said, look, we can provide services for fatality management. It took us several months to get this contract done. And 2 weeks before the Albert Pike tragedy, we inked the contract with Kenyon International. So what happened? Well, what happened was during this incident, a local coroner called the Department of Emergency Management on the day of this incident and said, we're recovering bodies, and I need some help. I think I can identify all of them, but I'm not sure. We got word of this because we had been working, we'd known about the incident, and we called Kenyon International. The coroner, we went down to the incident, traveled down there, went down to Albert Pike. The coroner had talked with a refrigerated ice delivery truck company. The company said, we can, if you need storage facilities for more bodies, we know you're recovering. You've got 6 to 10 bodies you've recovered. If you think you're going to recover more, you can use one of our trucks to store the bodies in. And the coroner said, that's a good idea. But then the company said, by the way, you're going to have to buy that after you store the bodies because we can't use it again. We went down, talked with the coroner. We called Kenyon, and Kenyon had an 18-wheeler that afternoon come down, late afternoon, and sit near the body recovery zone with a refrigerated truck in case more bodies were found. So 2 weeks before this incident, we just inked the contract, and now we call Kenyon. Kenyon assisted in identification of the bodies. Kenyon assisted the local coroner. And so we learned a lot that, yeah, this system works. Now, the local funeral home, by the way, when we went there, they had a walk-in cooler. The bodies were stacked. And so the funeral home was at its capacity at 20 bodies. The refrigerated truck was there in case more bodies were found. We didn't find any more bodies, but the truck was available. And it was a very hot June, by the way. And the bodies quickly were deteriorating, and we were very concerned that if they found more bodies, the capacity of the local funeral home in Mena, Arkansas, was already at capacity. So what we learned from that is that this contract worked. It was a very timely sort of thing. We now have a good mass fatality plan as a part of our healthcare capabilities in reaching out. Our coroners are now part of our coalition. So, next slide, please. So the mass fatality incident is such as this one. It's an incident that produces more fatalities than can be managed locally. We are also concerned about the condition of human remains, the accessibility of the incident, possible multiple scenes of fatalities, complexity of remains recovery, and resources and capabilities of responding agencies. Again, with this particular private company, they manage almost all of this. They will manage almost all of this for us with regard to recovery of human remains and also working with the families of the victims. So, next slide, please. So there were no survivors. There was no hospital surge, but there was a surge with regard to human remains. So our coalition then involved our coroners, and we realized then that we had a real problem working with coroners in Arkansas. Do they know about mass fatality? Do they know how to work with the Department of Health in recovery of human remains. Our take on that was they did not. So next slide. So what we did there was we went to the legislature to develop a coroner's law, a statute for training of coroners, to establish education programs for coroners, establish a mass fatality and mutual aid agreement, establish a coroner's education training, and importantly, a certification for coroners in their training. So once our coroners attend our training course, and again, this is what came out of Albert Pike, was a law, an act, they can attend this. They will get certified, they will get trained in mass fatality management, how to work with the Department of Health, and that's what this was the best practice that came out of this event. This is what we learned from this event. Now, it's very important to know that in Arkansas, like many areas, our coroners are elected, so we cannot mandate that they enter into any training at all. We can say, here it is, we'd like you to engage in this training. So, next slide, please. So what we have and what we developed through our mass fatality response is mass fatality response kits. These kits contain cameras, checklists of items needed to identify bodies, and documentation at the scene. But that's the carrot for the coroners. In order for coroners to use these kits, they have to engage and go through our certification, our certificate program. It's 2 levels. Hopefully we'll be able to get it really down pat. But they have to go through our mass fatality training and working with the Department of Health in how to use these kits. They can't just use these kits without going through the training. So that's kind of a best practice for mass fatality. And we also work as a part of our coalition with our medical examiner's office, and we found that we actually had a good partner in our medical examiner's office, and they were very impressed with what we did, and they were certainly very important in assisting us in getting this law passed. We also worked with the Arkansas Association of Counties, and they were very positive in getting this law passed and also the funding of this. Now, lastly, I'd like to say that, next slide, please. This individual, Craig Cowart, is a pastor of a small church that sits at the entrance, near the entrance. It's about a mile from the entrance of Albert Pike, this campground. So this church sits on a little hill. This pastor recognized what was happening and opened the Landmark Missionary Baptist Church. It's called Pilgrim Rest Landmark Missionary Baptist Church in a little town called Lodi, near this campground. Opened the church up, and his members of the church gave a lot of rest, brought in counselors and invited counselors from not just from his church, from other areas to work with the victims' families. He was recognized by several different agencies for his help during this event and was very important to us. He rose to the occasion, and suddenly we had a coalition in this very small Baptist church. So suddenly from Arkansas, we have someone that opened up a church that gave of his time and of his church's time to help the victims' families. So in Arkansas, we kind of know everybody. Everybody pretty much gets along with each other, and we consider religious organizations as a part of our coalition, and Reverend Cowart is certainly someone that we didn't know before this, but he's certainly a valuable member of a coalition now that certainly would assist us in any way possible, as are other religious organizations. So that concludes my presentation. What we did, what we recognized, part of this involved legislation and bringing in coroners into our coalition and other organizations. And now I'd like to This concludes my presentation, and I'd like to turn it over to Gene Randolph to discuss community assessment tools, and thank you very much.
Thank you, Dr. Mason. Good afternoon. This is Gene Randolph from the Healthcare Preparedness Activity in the Office of Public Health and Preparedness and Response at CDC. I'm going to speak to you this afternoon about the Community Assessment Tool. This is a tool that was developed by the Healthcare Preparedness Activity. We began work on this in 2007, used it with a community in 2008. What we used at that point in time was a very rough draft and certainly a very scaled-down copy of what is currently on our Internet site. This tool is meant to provide a framework to build a coordinated, integrated response for surge to a healthcare system, and it does that by identifying the resource needs as well as partners that may need assistance in planning and overlapping use of resources which could lead you to a lack of resources. The partners that are included in this community assessment tool are listed on the slide here. As you can see, most of them are part of the healthcare sector, except for the three on the right-hand side, public health, emergency management, and local government. Those sectors are not actually involved in day-to-day care of patients. However, when there is a disaster, they are very important to the healthcare system. And so we included them in the assessment we put into this, the tool. I should tell you that the website at the bottom of this has just been discontinued, and the website that's listed on both your agenda and throughout this, and at the end of this presentation are the correct URLs to go to find the tool. The CAT was piloted, as I said early on, as part of a pre-workshop preparation. And when the community, there were two communities that used it at the same time. The workshop was a dual community workshop we were doing. And the communities that used the tool told us after they used it that they felt it would be very, very useful to other communities to do an assessment. And they helped us to develop it the rest of the way, as well as to be subject matter experts for us for content. They helped us also to determine priority questions, which, as you will see as we show you the pages at the end. But the partners that helped us were both local responders, practitioners. They were people from past workshops and meetings, as well as federal partners. Now, I've mentioned DOT and NHTSA there, but there were a number of federal partners that assisted us. The audience for this is a community planner, a healthcare emergency preparedness planner. If you have a coalition, your coalition lead would be a perfect person for this, and you might want to have a small steering committee work with that leader, because this is a pretty big job, and when you set out to do this to assess all of the healthcare sectors within your community, that is a large number of partners, and you want to have enough people that should somebody decide to change jobs, you have someone else to back them up. It informs the audience about the capabilities and resources within each one of those sectors. It also informs you of the gaps in those capabilities in the planning, as well as potential shortages in resources. The design and organization, each section is customized into part one, which should be filled out by either that coalition lead or emergency planner, or it may be that little steering committee. They put in the pertinent information, and to give you an example, if you were talking about urgent care clinics, all it asks is the name of the urgent care clinic, the main contact, and the either the email address or the website or phone number to reach them. And that's the listing that you put in part one. Part two asks the significant questions to get at the information about resources and about planning. The questions in each section can be edited, added, or deleted. And clearly, you should know that you have the ability to do that. You download the CAT into your computer, It's yours to use. You can customize it as you want to. And it is also not something where once you put information in answering these questions, no one has access to it except the community. The document is in Word format, as I just said. It can be downloaded. It's collected for the community's use and not shared with CDC. And questions marked with an asterisk, and those are the ones that you need to answer first if there's a limited amount of time available to complete questions. Around the time of H1N1, we had already posted this on our website, and people who were using it suggested to us that that answering these questions quickly helped them out prior to that time. So those questions are basically questions that address either regulations, state or federal regulations, or requirements such as Joint Commission requirements, and that's why they're so important. If they're not answered on the first pass or they're not answered with good information, whoever is the coordinator needs to go back to that group and tell them they have to get back to those questions and get that information put together. This is section J, urgent care centers, and this is part 1. And as you can see, as I mentioned to you before, the person filling this out is the community coordinator, healthcare coalition leader, emergency planner. First question is how many centers are there in the community, and that just means a total number, and then just list them out, and as you get the information back from them, you check off that they've completed it or not completed part 2. This is part 2, and as you can see, that person indicates the name, what role they'll play during an influenza pandemic, and several other questions, and there's an asterisk question asking if they have looked at how they might be able to increase their staff 30%, how they may be able to implement staffing if they have 30% of their staff who are ill and cannot come to work. That's a question that's important, and if you're in the middle of a pandemic, you want to know you've got a plan to get extra staff if you need it. This is the web address for where you can find the community assessment tool as well as a number of our other tools. The CAP-specific address is right there as well as our web address. There was a COCA call back in 2011 that went over this in much more detail, and that is archived on the COCA site, and the URL is there. We also have a listserv, and you can sign up for that and get updates as we put new tools out. We're currently in the process of beginning to update some of our tools, so the ones that have been out there over a period of time, 3 to 4 years, we're updating. The community assessment tool is this year in process of getting updated and made all hazards. Thank you. And now I believe I go back to the coordinator, or do I? Oh, I'm sorry. The next person to speak is Randy Bolts from Howard County. Randy?
Randy, you may be on mute.
No, I believe I'm on now. Can you hear me?
Yes.
Okay, sorry. My name's Randy Bolts. I'm from Howard County Medical Center, and we're trying to get our first slide up. We're not able to see it, unfortunately.
I'll just go ahead and take it back, Randy. That's fine.
Okay. Sorry. But what we're going to kind of discuss today is how we actually used the CAT. We worked with the CDC last spring, and they asked us to do this because they were going to assist us in planning a workshop for planning for pandemic or public health emergencies.
Next slide.
Next slide. You can do the next slide too. Thank you. The population of Howard County is just over 6,700 people. St. Paul is about 2,300 people. The healthcare facilities that we have in Howard County, we have Howard County Medical Center, which is a 25-bed critical access hospital. Along with the hospital, we have 2 rural health clinics, one located here in St. Paul and the other one in Greeley, Nebraska. And we also have 2 retirement homes and nursing homes in the facility, or not in the town, sorry. We do a little bit of coordination with other facilities, but unfortunately it's not really enough. Grand Island is a community of about 50,000, and they're about 25 miles from St. Paul. St. Francis Medical Center is the largest tertiary hospital closest to us, and we have not really completed any recent coordination for any types of disasters. However, we do have transfer agreements in place with them. And we also kind of work with Good Sam Hospital in Kearney, Nebraska, which is about 70 miles. But again, we haven't done any extensive coordination, but pretty much have transfer agreements in place. We also work with Emergency Management, Luke Basin Public Health Department, and the Healthcare Coalition of Tremors, which includes 19 hospitals in a 23-county region. We also have MOUs in place with all the hospitals through the Tremors organization. Next slide, please. So why did we use the CAT? We found that it would help us provide a list of partners to engage with our planning efforts and to see where our to help identify planning and resource gaps within our community. It helped us form the creation of a consolidated list of community resources as well and find where we had resources that we didn't know. It provides information on the capabilities of hospitals and other partners in the community and partners outside of our community as well. Next slide. The Howard County Planning Team had a conference call to brainstorm on who should fill out the CAT. We all came up with similar people, but everyone came up with additional names. So together we were able to come up with a comprehensive list of people we knew would be able to assist us in filling out the CAT and assist us in our future planning efforts. In rural communities, people have multiple roles, and sometimes priorities have to take precedence. We had to remind several people multiple times to fill out the CAT for our project. And we tried to emphasize how important it was to have this completed for the workshop and for our future planning efforts. Because people have multiple roles, our emergency manager assisted several partners in filling out their sections. She came up with unique ways to be able to get the CAT completed. She called several people and asked if they had a few minutes to go over the questions, and she would actually write down the answers. She went and visited several people and asked the questions while they were actually doing their other responsibilities. She also completed one of the sections over the phone while the person drove to their next job site. Each planning member received a copy of the completed CAT to review once we were completed. We discussed the CAT together, and this helped us to identify what part of our plans and resources are working well and what needs improvement. Next slide, please. Howard County had the assistance completing the CAT from agencies outside of Howard County as well. As a rural community, we know we don't have all the resources we will need in a public health emergency. We have to partner with other emergency managers and hospitals in order to receive the resources and support we need. We need to know the extent of their capabilities, resources, and how they would handle staffing issues or need their assistance just to get supplies. We had the 911 call center fill out a section, and we found that they only have one person there at all times. We have a clinic manager filled out a section. For emergency management, we had our Howard County Emergency Manager and the Hall County Emergency Manager fill it out. We also asked St. Francis and Good Samaritan Hospitals to fill it out so that we could know kind of what their resources were and what their planning were for additional staff and things. We did ask the 2 local nursing homes to fill it out and also mortuary services. pharmacy, and public health. Next slide. We use this in the preparation of our workshop, the planning workshop for addressing healthcare surge in rural settings. It served as a catalyst to share the CAT with members of the Tremors members because we believe that this would be a very useful and important tool for all hospitals in our area to employ. If we could get to a point where hospitals use this with their communities, we could easily more identify regional capabilities and opportunities for enhancing those capabilities to support the region as a whole and individual communities. It is likely that what we found will be very similar in other rural areas of the same size or even areas that are larger. Next slide, please. Our 911 call center, we found out, consists of only one person at a time, and they also serve as the police dispatcher. So they're very limited in what they're able to do by themselves, because if we were to have a public health emergency, they're going to be overwhelmed very quickly. Our local EMS will be overwhelmed as well, because our EMS squads are all volunteer and have low numbers of units. Many EMTs may be unavailable due to their employment requirements. We may need to use EMS transport from services outside of Howard County. Next slide, please. The clinic will be overwhelmed with new and existing patients. It's possible that patients will come from surrounding communities if their regular clinic is busy, and we kind of really see that coming from Grand Island because of the number of clinics that are there. They think they might be able to get in quicker because it's a smaller community. Long-term care facilities may need to take care of any overflow patients that we may have or that are not critical enough to be admitted. And our mortuary services, the capabilities are limited, including for storage. Next slide, please. For the hospital itself, some of the limitations that we found, of course, our bed capacity will be limited because we're only a 25-bed facility. We don't have any ventilators, and we only have one respiratory therapist. Patients requiring ventilators may or may not be able to be transferred to another facility. These facilities may also be overwhelmed. The level of transfer would have to be an ACLS. If we could get ventilators, we would need to do just-in-time training for all the nursing staff. Next slide. In a public health emergency, we would really have to consider rapid discharge. We would definitely cancel elective procedures. Staff and supply agreements between hospitals may not be sufficient or usable during a large-scale event. We may not be able to utilize staff agreements in place between all the Tremors hospitals during a pandemic. We need to collaborate planning between Howard County Medical Center and St. Francis Medical Center in Grand Island and Good Samaritan Hospital in Kearney to understand how practitioners will deal with crisis standards of care. In Nebraska, as with other states, people actively avoid discussing the topic in any meaningful depth. We have traditionally lacked leadership when it comes to bringing the right people to the table to discuss this. For instance, the state, the Hospital Association, and the Medical Association have all stated that they have not talked to hospitals or practitioners about this topic. During our workshop, the Nebraska Department of Health Human Services attorney discussed what DHHS can and, more importantly, cannot do with crisis standards of care because of the boundaries of the regulatory authority. We need to work with them and the associations to bring people to the table so that conversations can begin to take place. Next slide, please. We found that some of the terminology could be confusing to different sectors of personnel. Some of the areas, for example, of the CAT didn't apply to our local health department, Loup Basin. Nebraska's health departments are structured differently to accommodate rural communities. Some questions referred to health departments that were located in the same town as the community. It is very different for us. We're a small regional health department and located an hour away. It asked about specific things such as labs in the community that public health would use, we only use the Nebraska Public Health Lab in Lincoln, which is 2 hours away from St. Paul. Individuals who complete a section may not know all other sectors' information. It did not capture all the resources that we found out at the workshop about additional resources that partners had within our collaboration. During the workshop, an EMS representative identified a cache of donated materials and supplies that we had in the community that we had no idea. The public health section of the CAT was written more about one county, high population health department, and didn't really apply to our Frontier Regional Minimal Staff Health Department. It asked about specific things such as labs in the community, but yet, like I said earlier, we would use the Public Health Lab in Lincoln. And of course, we found that it was very difficult sometimes to get people to actually fill out their sections. Next slide, please. By completing the CAT, we actually found a lot of benefits out of the whole experience. It helped us to identify a lot of assets. Like we had a good start in our planning efforts and plans. We found that we had extra supplies in the community. For our needs, we did find out we need more planning, and we need more planning partners. For some of our strengths, we already have some community collaboration, and we're now looking to build on that a lot more. As far as a weakness that we found out, have a very small number of volunteers, and unfortunately, that number is getting smaller all the time. As far as some building blocks, it helped us begin our local emergency planning committee meetings with partners sitting around the table. It provides a good overview of the community resources, especially helpful for new people and partners in preparedness roles and when they come into town. It seemed to be really overwhelming at first to do the CAT, but then came to see how valuable the tool really is. And when you break it down by sectors, it's very easy to understand. It helped us connect and reach out to partners that we don't normally connect on a regular basis. And now we're going to try to keep them involved as well. It helped us realize that we need more partners in our planning and to get through a public health disaster. And also important to it's important to include and learn about resources everyone has and what they don't have, so that you can try to get everything in place. And that's the end of my presentation, and I'll turn it over to Leslie Schulte.
Thank you. My name is Leslie Schulte, and I'm a Public Health Emergency Response Planner in Region H, and I would like to share with you the Region H Healthcare Emergency Preparedness Coalition development in Missouri. For reference, Region H is the northwest corner of the state of Missouri within 15 counties. We have just over 239,000 people, a population density of about 32 people per square mile. A couple unique landmarks. We have 3 universities and colleges, 5 correctional facilities. We have 1 nuclear power plant across the state lines of Atchison County, and we border 3 states of Iowa, Nebraska, and Kansas. You can see we're a very rural jurisdiction, a lot of farmland, sprinkled in with a lot of industry, and our largest area is the city of St. Joseph. Prior to 2010, the Region H Health Resource Committee was presented and brainstormed and developed by the hospitals and health departments of the region. We looked at each other and said, we're a rural jurisdiction. If something were to happen, we know we would need each other to be able to respond. And so the group started meeting over a lunchtime period, would share agency, facility, updates, and develop relationships that consisted more of just a name and a phone number on a piece of paper and a plan in our office. We really worked on getting to know each other and how to communicate with each other, not only during business opportunities and meeting opportunities, but how that communication would then roll over into an emergency or disaster. And then the biggest piece of the Region H Health Resource Committee was about resource sharing. We really felt we needed to find out what we have in our region and how we can get to it if we ever get to a point where we need it. Initial challenges for the group included lack of guidance or national models in which we could develop the group, especially into the planning and response phase. We were able to manage getting together and sharing information, but really into that planning phase, we didn't have a lot of guidance going forward. In 2010, the Missouri Hospital Association sent letters to our health departments and hospitals through the region asking us to attend a meeting to discuss regional coalition development. It was a statewide effort. So we went to the meeting, and I remember listening to the presentation and how things were developing into a coalition and looking at our partners in the room and saying, this is what our Health Resource Committee has been doing and we're moving toward, and it became a very easy transition into a coalition. An easy fix was to change our name and move toward the development. So MHA was able to push out some of that guidance that was missing from the early stages of our coalition, providing now mission, objective, memberships, suggestions, and guidance as we move forward. So the Region H Emergency Healthcare Coalition, current membership, we have 9 hospitals in our region, 7 critical access hospitals, our 1 trauma center in the city of St. Joseph, and our 1 state mental health hospital all have membership to the coalition. We have 13 local public health departments representing 15 counties, and in our region we only have 1 federally qualified health center. They're also represented, as well as the 5 Department of Correction facilities, employee health nurses. American Red Cross has become a member over the years, especially related to the sheltering issues and functional need pieces that have come along. In 2013, we engaged EMS and emergency management, bringing them on as 1 as a member but 2 as a liaison back to their own discipline. So our EMS and emergency management coordinator are members, and they go back to their own entity meetings to make sure we have communication across all agencies. In 2014, we hope to engage a new membership in our regional mental health providers, as well as figuring out a connection with long-term care centers. In addition to that, we've had discussions about a coroner and how we can bring them on so that we're covering as many of the EFS8 functions as possible. Current leadership for our coalition, we have 3 facilities that take the leadership role and form the coordinating council for the coalition. Currently, myself as a public health planner, 1 of our critical access hospital planners, and 1 of our trauma center hospital planner serve in that coordinating council role. The 3 of us then report back to the Missouri Hospital Association Coordinating Council, which is made up of all of the leadership of the coalitions across the entire state. In 2013, we increased our leadership through subject matter experts in our coalition. We brought on a communications expert who really has taken that piece on and works with every bit of a communications equipment for the coalition. Our exercise subject matter expert has helped make sure we have good value-driven exercises on a timely manner, and coalition development expert, which includes our documents, attendance, meeting minutes, membership, those types of things. In 2014, the Missouri Hospital Association will push out decon training centers through the coalition, so that will be a new subject matter expert for us. And specific to our coalition, if you remember when I talked about the old days, resource management was very important to us, knowing what we have. And so at our coalition level, we've discussed having a subject matter expert who comes very detailed in the resources within the region, what we have, where it is, and how we need to get to it. For example, if it's a trailer of supplies, what type of truck is needed to move that trailer, what size of ball, that type of thing. First steps for developing our coalition and the beginning, as well as every first of the year. So January's meeting included these things. We developed our routine meeting schedule for the entire year. We use a combination of face-to-face and conference calls. Early in our development, we felt it was important to meet every other month, so we did conference calls on the off month. For 2014, we've moved into the development phase fairly well, so we've pushed back our face-to-face meetings to quarterly with conference calls between. We do use meeting locations all across the region so that you can attend 2 to 3 at least of the face-to-face meetings throughout the year. And of course, our contact information we keep current and adding our redundant communication systems as they become available. For example, Missouri has pushed out and will continue to push out an interoperable system across the state of Missouri called MOSWIN. As our coalition members receive that equipment, that communication system will be updated for use in our coalition efforts. The mission statement of our coalition is to improve all-hazard medical response for the region through support of our healthcare organizations, providers, and regional partners by facilitating all-hazard planning, coordinated exercises, and real event response during mitigation, response, and recovery phases. When we talk with each other at meetings and when we started brainstorming what we want to do as a group, it was really about improving the overall health system response for our entire region. And the things that we use to do that include our planning, exercises, and response to real events. Looking at objectives, we have two different types of objectives. Under the planning section objectives, we wanted to identify the hazards across the entire region, get outside of our individual facilities and look at the entire region, and then discuss mitigation strategies for those hazards. In training and exercise, we want to have timely, value-driven exercises and training related to specific things we'll be using, such as online systems as eMresource or WebEOC. We identified our regional strengths and shortcomings as well as developed a regional plan. And that plan, like every other plan, is continually adapting and changing, and we're adding pieces as we can. Under response objectives, information sharing and situational awareness we recognize is very important during any event response so that our health partners can make the best decisions that they can. So it's very important during a response our coalition provide accurate and timely information sharing across the coalition. And, of course, resource support, again, knowing what we have available and how to get to it. We want to interface well with our local Emergency Operations Center as well as our multi-area coordination center. And then overall coordinate our coalition's response activities. A success that our coalition has is the statewide implementation of eMresource, an online computer-based system in which we can look at the screenshot you're looking at is the Region H, and you can look at by region, you can look at by state, but it gives you an overall picture of how the facilities are functioning. You can see Emergency Healthcare Preparedness Coalition is listed on the top under normal operations. All of our hospitals then are listed below and their current status, followed by our regional assets, and as the screen rolls down, all of our local public health agencies can then list their operations. Up here by Region H, Emergency Preparedness Coalition is a set of keys, and if I were to click the set of keys, our other success is a regional notification system. This allows me to change the status of our coalition based on the need that we may need from our members. If we were to need them on advisory, an event may be happening, but no response is necessarily required, we might put somebody on advisory for a winter storm coming through. On alert means there's a possibility something did happen or may happen that may lead to a full activation. And of course, full activation means our coalition members need to please respond. So within a click of a couple buttons, a few comments, I hit save, and all of our coalition members within a few minutes will be notified of an event that is happening. That notification then triggers them to log on to this system for more information. Also within eMresources, the development of the Hospital Incident Command System. This system allows our coalition to virtually have a response to an event anywhere in our region. So from our own offices or my own desk, we can log in and assign coalition members to specific positions that may come with objectives and things that we need assistance with in the response. First question I get from a lot of places, well, if you're the agency being impacted, you don't have time to sit down at this computer system, and that's exactly correct. As a coalition, we recognize the agency or facility that is impacted by the event may not be sitting at their computer, but behind them the coalition has stood up on the Incident Command System structure and is ready to help them with anything that they may need, and this is one way we can share information very quickly as well as resources. We completed our regional hazard vulnerability analysis. Each facility and agency is required to complete their own HVA. We took a look across the region at the types of events we may have, the probability, risk, and how well we are prepared to identify our top hazards for our entire region. We have an exercise schedule. Again, we do it at the beginning of the year and set it for the entire year. In 2013 and 2014 looks very similar. At least twice a month we're testing some type of communication tool. And 4 times a year we're testing desktop exercises where we all remain in our offices and our agencies and test our HICS application. We also participate in the State Emergency Management Agency exercise in the fall. Another success, the formalized guidance that comes out from Missouri Hospital Association. I can't say enough about the team at MHA who helps bring guidance in and prepare it to come to the state-level coordinating council of coalition leaders who can then sit and look at documents and say what works well for local coalitions and what does not work What this allows is documents can be tweaked instead of having to be developed at the coalition level. It's provided a lot of consistency across the state, and it gives the state coordinating council the ability to have that voice and that input into it. The Missouri Hospital Association has always taken the approach of an 80-20 look when we're looking at documents. If we can look at a document and know 80% of this document can stay similar, so it stays similar across the state, but they recognize each coalition throughout the state of Missouri has been set up differently, you do need to change things based on your coalition. We take that approach in all the documents that come from MHA. We've worked really hard to develop a relationship with our emergency management directors and our multi-area coordination center. We've established our coalition as a health response within our MAC, and we've participated in state emergency management agency exercises. We started this process with presenting our coalition development and approach as well as our HICS application at our regional emergency management coordinators meeting. At that point, we knew they were in the development phase of their MAC. We've been testing it a couple years. They've asked the coalition to be a representative in the MAC development so we can make sure we're staying on the same page. Emergency management directors, they're in the command chair of every incident. We wanted to make sure as a coalition we were falling into the structure they were developing. Coalition exercises over the last couple of years, we've participated in several things from the 2010 national level earthquake exercise, hoof and mouth, several ice storm and or tornado storms. We continue with our communication test and our notification testing. In the future, we look forward to an asset moving test of some sort. Coalition response experienced recently in May of 2013, a late snowstorm moved through the area, dumping heavy wet snow, which took down power in 3 of our counties, including 2 of our critical access hospitals. Coalition members in that counties put the coalition on alert status so they could share information and provide regular updates, as well as have agencies and entities ready if conditions were to deteriorate throughout the day. In October of 2013, a town of about 10,000 in our region expected a demonstration of about 3,000 people. They knew that 3,000 people could potentially disrupt their health system, again, putting the coalition on alert. It was a peaceful demonstration. We had no issues, but they felt the need to reach out to provide information and be prepared with resources if needed. So when I look at our coalition and the things that the coalition offers, sometimes I'm asked why join or form a coalition, especially when we're talking with other entities or agencies about potentially joining our coalition. Our coalition has really given us the avenue to develop relationships for a whole health system across our region. We've gotten to know each other very well and know what we all bring as far as assets and personal assets to our group. Information sharing has picked up immensely over the last several years among our health entities across the entire region, whether it just be a training opportunity, information, or maybe it's even information about the influenza cases that we're seeing recently. And again, human and material assets are very important to our region. As we know, we're a very small rural area. We're going to need assistance from each other, so they provide that additional support. I guess I'd like to end this piece with the idea that the support that the coalitions provide to our entire region. When we have an event at the local level, the coalition does not come in and say, we are command and control, we're here and we'll take over. At the local level, if something were to happen in Holt County, a county I support, our Holt County Health Department would report to our local EOC as a health representative and would take care of health needs at the local EOC as Holt County can. At the point where those needs exceed the ability to respond, standing behind us at Holt County Health Department is a network of 30 other healthcare entities and agencies across our region. So if we have a need, we very quickly can move things. Next step for our coalition, we look to continue our regional plan development as well as our exercise development and improve our leadership depth. It's very important at our coalition setup virtual the way we have it, that every coalition member feels the ability to take a role and be ready to respond. And the last thing I would like to share with you is a resource and a link to the Missouri Hospital Association guidance documents put out in 2013. This document will give you an overview look at all the coalitions across the state of Missouri as they're all set up just a little bit different based on their needs. as well as an MOU that coalitions are moving forward in signing this spring, as well as 2 planning documents, one being information sharing and the other mass fatality planning. Thank you for your time today, and I will turn things over to Jay Taylor and his team, who will discuss medical surge in a rural setting, the Greyhound bus rollover.
Thank you so much, and I really appreciate the opportunity to give a quick presentation here on incidents that occurred up here in around our central part of our state with a bus incident with a tractor trailer out on an interstate. Today we have Stan Hudson with me from Evangelical Community Hospital and Amanda Krebs from our EMS Regional Council up in that region. Just to give you kind of a layout here of the state, we have 15 regional EMS councils across the Commonwealth of Pennsylvania. And we also have 9 regional task forces. When it comes to our coalitions in the Commonwealth of Pennsylvania, it should be noted that we were fortunate here that a law actually created the task force many years ago and really molded into the National Incident Management System. And each one of these task forces all have the ESFA function within there, a health and medical committee that really represents our coalitions that bring all of our hospitals and our emergency medical services and all key players in the health and medical arena to the table at each one of these coalitions or our task forces. So we're quite fortunate in the way that has been built out and made it real easy for us to build coalitions here within the Commonwealth of Pennsylvania. On 9 October at 1:36 a.m. in White Deer Township, we had a vehicle accident involving the bus and a tractor trailer. It should be noted that the 48 passengers on this bus and the driver, when the first units arrived on scene around 1:41 a.m., we had the incident noted that there was like 8 to 10 feet of intrusion into the bus. So we're talking about a real heavy impact on this bus and had the potential to be probably a lot worse than what it actually was. The other part of this too is where they're located out there is being in a remote area out in Pennsylvania. There ain't immediate access to where you would have close to a city for health care, but we do have a robust system in place out there where we're able to respond rapidly and get the resources that were needed. And you can see that the scene was secured at 5:44 a.m. that same day. EMS units, we had 25 of them that were involved from 6 counties, which included 3 of our EMS councils, 16 BLS, 9 advanced life support, and 3 air medical units that responded, and 46 patients being transported to 4 local hospitals. And of course, we had one who was deceased on scene. So. The level 1 trauma center in that area was Geisinger, who received 18 patients overall. 2 were actually transferred for definitive care from one of the other hospitals, from the Evangelical Hospital, who had received 14 patients. Muncie Valley received 10, and Williamsport Hospital had received 6. And I would think, and I'll let our folks there out in that region actually give you the kind of distance in which they were traveled. I think it was probably around 20 to 30 miles in any directions for some of these hospitals that they had to travel to. So the incident was managed very, very well. The accurate assessment by triage obviously was the key to getting control of the incident, and also was a key part of having the proper person sent to facilities that were capable of meeting the needs of that patient. They had the process alone could save considerable time and conserve valuable resources by getting those assets that needed to be back at the scene to transport somebody else back on scene quickly. Obviously, as I mentioned, that the triage was very, very right, and it was very critical to the whole operation to have someone able to do that. And interoperability. You have 25 EMS companies coming in from 6 counties, 3 regional councils, who had fire department, law enforcement, all work together with a common cause. And obviously that is the overall objective of having a coalition, is having that working together in that common cause. And the incident command worked well on scene, as well as the hospital incident command. Obviously, what can be improved, there was some, issues on scene with the patient tracking, being able to knowing the number of people that you had, the number of where you sent those individuals to. Leadership, some of the initial people who took the leadership role were very inexperienced. They did step up and they were able to take control of the situation, but they could have done a lot better, obviously, with experience. And obviously, you don't have these types of incidents out in these locations happen every single day. Information sharing, that become one of the issues, whether it was HIPAA related in some hospitals and their policies and being able to communicate across and with each other became probably some of the more, some of the difficulties that were experienced during this incident. And with that, Amanda, I'll let you speak to the EMS side of the house and some of the things that you noted there for the incident and how we came together as a group.
Okay. Well, like you had said, there were 25 EMS units responding from 6 different counties within the central Pennsylvania area. All of those EMS units were able to communicate with each other through the 911 center. And the 911 center, upon learning of this incident, quickly notified all the hospitals in the region and told them what was going on and said that they should be expecting a large number of patients. So fortunately, all the hospitals, except one, I believe, was notified and were prepared for the amount of patients they were going to receive. Like Jay said, the triage, they set up triage outside of the bus and inside. They had one paramedic go inside the bus and start triaging patients. And as he said, with the lack of experience, I do want to bring up that both of the paramedics that initially responded to the call have been paramedics for less than 5 years. So this isn't anything that some of us who have been in it for 20 years have seen, let alone people just coming in off the street. All in all, everything went very, very well. The biggest challenge to the EMS that was on scene was the fact of the language barrier. I believe only 2 or 3 of the patients on the bus spoke English. There were 6 or 7 languages represented. Fortunately, one of the firefighters from the company who had initial incident command was able to speak Russian and communicate with 2 of the victims. And I believe one of the EMS providers was able to speak Spanish and communicate with others. But some of the patients, excuse me, were Korean, and the deceased was actually Vietnamese, which was another challenge in itself. So triage and treatment areas and finding for the incoming EMS to actually locate the patient was very difficult because with the limited resources, keeping victims who can't speak English and are scared to begin with in a small location for treatment was very difficult. Excuse me, I'm suffering from this cold that everybody seems to have. But generally, the treatment and transport went well. I believe if Stan is on, he'll be able to help you out with the hospital side of things.
Dan, you on?
Yeah, thank you, Jay and Amanda. I would say that our hospitals did a very good job. We were all able to set up a hospital command center, and through that we were all HICS compliant and used our NIMS compliant, and we used our HICS command system to manage the situation. I don't think that would have been possible a few years ago, but because of the funding we received, and I know here the Pennsylvania Bureau of Public Health Preparedness has stressed that we use our funding not so much with the purchasing of equipment and the toys, as they say, but to direct it more towards training. All of our coalitions have seemed to do that, and it really paid off here. We were able to manage it the way it should be managed. We were all on the same page. We all use the same terminology, so it worked out very well. And I would also say that the communication that we had between the hospitals worked out very well. If I could just kind of mention, without predating myself, you know, a few years ago, hospitals looked at themselves as competitors, and that still may be true to a certain extent, but through the coalitions, we sit down with one another at the different regional sessions and meetings. We get to know one another face to face. So we look at it more as a cooperation. There's times when we're individual, but other times when because we sit down and come together, we've learned the importance of cooperating one with another. So that's been a big, big plus in how it was handled. All the hospitals did basically the same thing, and I thought they all did a good job.
Thanks, Dan. And I will note is, you know, the things that went right, and part of the HPP program, what they've done for us is, you know, bringing those hospitals on board with the incident command system and getting them in compliance with that, and building those command centers and having those instruments in place really contribute to the success of the overall operation and how well it worked. And obviously we're going to continue to build on that and grow our regions and our coalitions to continue to be the best we possibly be. And so with that, I will turn this back over to our host, Tracy, and for questions and answers.
Terrific. Thank you guys so much. I think from everybody listening in, we really appreciate the questions for the presentations and what everybody had to share. I'm hoping the operator will kind of queue up how we go about questions for the folks on the phone. But we did get a question for Dr. Mason, specifically around who within the hospitals operates the ham radio. You made reference to that in your presentation, so folks were interested in that.
Local ham, they're trained, John, they get the tips or something. Yeah, the local ham operators are trained by our communications person to respond to the hospitals. So we also have, I know we also have some ham operators within the hospitals. We have training for the hospitals with local ham operators.
Monthly tests.
Yeah, and monthly tests also.
We're starting to do some training in schools too, high schools.
Yeah, and also Steve mentioned that we're doing some training in some of our local high schools with regard to ham operators. So we want to reach out to some of the high schools that have an interest in ham operator clubs and make sure well, I think they would be part of a coalition also.
Great. And a follow-up question for you, Dr. Mason, is I guess some of the folks on the phone are interested in wondering, maybe you will or won't know the answer to this, but do you know if there are other states who are using the certification class for the coroners in addition to the work that you guys are doing there in Arkansas? Is this something you've heard mainly that you guys are taking the lead on?
Yeah, we have something called the Arkansas Law Enforcement Training Center in a little town called Camden, Arkansas. And what we're working with the Law Enforcement Training Center is to develop kind of level 1, level 2, or a basic course and an advanced course in certification and training for coroners. Okay, now it doesn't certify a coroner, but they've got basic and advanced training. We're basing that off of a model. And I'm probably not correct here exactly, but it may be coming out of St. Louis University and also New Mexico. They have apparently some very good modules for coroner training. Okay, and I can certainly, if we can get you information on this, if you'll just send a note to Steve Wisnett, I can send you the information. Also, I was preceptor for an MPH student. She did an excellent research paper on coroners in not only Arkansas, but within the United States, about the various coroners, whether they're elected, whether the coroners are medical examiners, whether they're a mesh between medical examiners and just elected coroners. We can send that paper to you also. That paper also we sent to the CDC. It was kind of the first of it was a very good outline of coroner training in the United States. To my knowledge, there are probably a couple of areas that, as I said, one in Missouri, and I want to say it's in St. Louis, and one in New Mexico, Albuquerque, that have what I would call the really the excellence in coroners training. And some of our coroners have actually gone up there. It's not inexpensive, and it requires time. And remember, these are elected officials, and I'll just give you of interest, the coroner that was at Albert Pike actually he owned a pawn shop. So you can see how much education he would have had in something like a mass fatality event. But we are just ramping this up right now. We are through our legislation, we're just getting it started, and we'll be happy to share any information that we have with other states. If they're interested, if they could get with you, and we'll funnel out whatever we have to any interested parties that are on the call today.
That sounds perfect. I appreciate that. And we'll try to get that material up with all of the other material from this call, as I mentioned earlier, that will be up on our website. We've had a couple questions circulating around how the materials will get out. The distribution center, the way that we distributed the information about this call, hopefully through the HPP listserv, as well as your project officers, your field project officers trying to share, and then the state level leadership being able to share with other state partners and local partners. We ask that once we get the link out that folks continue to share in that same fashion. We certainly don't want to miss anyone. So we have a question. Go ahead.
Can you give the instruction for how to ask questions via the conference call, please, operator?
Certainly. Ladies and gentlemen, if you have a question on the phone lines, please press star, then 1 on your touch-tone telephone.
Tracy, I had sent you a couple questions via email. Did you want me to read those, or do you want to?
I can proceed. I just wanted to give a second for the folks online.
Okay.
So we had another question. Jean, I'm hoping maybe you can take this one, wondering about how the CAT is being piloted with the awardees. How did you sample your pilot sites, or how were your pilot sites selected for the assessment?
We actually have done workshops with a number of communities across the U.S. When we did these pilots, it was back in 2008, and we were working with 2 specific communities at that point in time. We did not have any SPEP capabilities at that time, so we didn't actually have awardees. Well, there were awardees, but we were not working with them. So we worked with communities that we were doing workshops with, and they actually were communities that represented very large urban areas, mid-sized cities, and rural areas such as Howard County. And we've asked all of those communities to work with the CAT prior to our workshops and give us feedback about them.
Great. Thank you for that. We have a question for Pennsylvania. Specifically, how did the ambulance transport drivers know which hospital or facility to go to? Who determined that destination?
Obviously, the incident command on scene, you'd have a transport officer there that would determine where to send each individual that is being removed. And through our coalitions and through our planning efforts in those type of regions where we communicate and have everybody at the table through our ESFA component, we know the capabilities of the hospitals that are in that region. So it's pretty easy to send those who are severely hurt, who are a priority. You have a level 1 trauma center that is fairly close by, and that is on automatic. You're sending those patients to that type of facility. Stan, do you want to add anything to that?
Yes, I could. One of the things that made it successful was the triage that took place right at the scene. And our triage officer was pretty familiar with the level of acuity and what hospitals could handle what level. So they saved a lot of time by getting those patients to the hospital that was best suited to handle them. Like Jay just mentioned, all the Reds went right away to our level 1 trauma center. They knew what type of patients we could handle at our hospital, and some of the real minor patients were sent to another hospital. So they were familiar with it. They did a good job of triage, and they pretty well knew where to send those those victims.
Great. Thank you. So a few additional questions. One for Missouri. The question is, are all healthcare coalitions in Missouri regional, or are there more local-based coalitions as well?
The coalition set up across Missouri has gone by regions, with the one exception of Southwest, and they have a little bit different setup. They have a larger region outside of just our highway patrol regions that we use, and then they have sub-coalitions based on the large geographic area they cover. It's broke down smaller then into smaller local coalitions.
Thanks, Leslie.
Mm-hmm.
And then for this is for the, go ahead.
I'm sorry, were there any calls from the teleconference or questions?
Yes, we have a question from Nathan Rubio. Your line is open.
Hi, good afternoon. Thank you. It's not necessarily a question, but just a quick little thing that we did at our coalition, our HPP coalition here in Laredo, Texas, is we incorporated a gentleman from Texas Department of Public Safety who manages a CERT team. And what they do is it's a community emergency response team, and every one of those individuals is HAM certified. So in the event of a situation or a mass fatality or mass casualty, just a big exercise, they provide volunteers, and what they do is they sit them at hospitals to man ham radios. We've also included the local authority on ham radio in our coalition as well for our communications. And they provided a huge amount of expertise and a huge amount of help and guidance in that aspect for redundancy. Not necessarily a question, but just something I wanted to throw in there and to show that what we're actually doing with our coalition and the diversity that we have. Thank you.
Great, thanks, Nathan. We really appreciate that comment. I think that's one of the things that people have echoed throughout the course of the calls today is, really just trying to identify some of those unique partners, and the CERT members being HAM certified is certainly one that we should consider taking advantage of if folks haven't already. Operator, do we have anybody else in queue?
Again, if you have a question, please press star then 1.
So I have another one that came in through the web. I'll take in the meantime. I think this is probably open for the majority of the folks on the call. Do any of your coalitions charge for membership, and is this something you're moving toward?
In Pennsylvania, we have no charge as a membership. Like I said, it definitely is. It is just partnerships that we've developed through relationships with all of our key partners.
Same thing with Missouri. It's a partnership of all the entities and agencies in the region that want to be involved.
And the same probably for Nebraska as well, wouldn't you say, Randy? I mean, there's no
Nebraska's the same way. We do not charge any fees to be a part of a coalition.
Same with Arkansas.
Anybody in queue, operator?
I show no further questions.
All right, I got an additional one via web. Did any of the presenters who shared regarding mass fatality incidents coordinate with county justices of peace? That's probably for you, Dr. Mason, maybe to kick off.
Well, we do coordinate with our county judges, not justices of the peace, but county judges. They play a very important part in our counties and our coroners also. So we do make them aware of our mass fatality through the coroner training, through Kenyon's contract. They do go out and talk with our various counties, including county judges.
Great. Thanks for that. I think we have time for one final. Operator, did you get any?
I show no questions.
Okay.
Casey, we have one here at HPP.
Yeah, this is George Silverman, the Hospital Preparedness Program here in Washington, D.C. And we talked a lot about information sharing and all that, and I guess this question goes out to Leslie. You had mentioned about keeping the contact information current, et cetera. Now, What kind of carrots and sticks do you use to make sure that everybody keeps their data updated and contact information, et cetera?
I would say it's just, if the coalition was answering, it'd probably be more like Leslie doesn't leave me alone until she gets the information she's wanting. But most of the time, it's put out on a coalition library within our HICS application, and I ask coalition members if they notice any changes, they can make the changes themselves. They don't have to necessarily go through any one person. But basically, you know, membership gets those three major components we talked about. Partnership was all about the relationships, the communication, and typically that communication tool as far as knowing what's going on, what training opportunities available, typically lends pretty quickly to coalition members saying, here's a change and please revise it for me. So it's not been a struggle for the most part.
Thank you.
Tracy, if you want to go ahead and wrap up, and then Scott has a few closing remarks, I think we're good to go.
Super. I really want to thank our presenters, and at one point I looked up and there were 290 folks on the live meeting option, so I'm glad we got such a great audience for this. And like I said, we'll be getting the materials out, hopefully a link out to tell you where to go to be able to grab the information that was shared here on this call, and look forward to many more discussions around rural preparedness. Scott?
Thank you, Tracy. And you know, I want to thank Tracy Camilli for all her work in setting this up and you know, her dedication to the topic, and also to our speakers, our CDC colleagues, and the state and local presenters. Thank you so much. I think it's been an excellent call, and again, the first of what we hope to be many as we continue to explore this topic of rural healthcare coalition development, and of course, you know, the topic of rural healthcare delivery, which transcends with that. But in closing this call, I mean, I got a lot out of it, and if you're new to the call and new to this work, you know, one thing that this room, we're looking at each other, think we could take away is that you know, coalitions are forming in rural areas, and that's important. There's a need for it. Rural areas experience events. Small, and even a small event can have a big impact, especially with limited healthcare resources. EMS transport is certainly an issue, and thank the Pennsylvania folks for highlighting that. And I want to thank Leslie for talking a little bit about how the coalition works to find its way and assist jurisdictional command. So those are a couple of key takeaways that the room had here. Wonderful, and we want to thank all the speakers. If we had more time, we'd get into some more details, but we can always have a follow-up call, and most likely we will. This call will be taped, and when we get our website finished, we're going to be posting the call conference there, so folks can re-listen to it. And with that, we can close out the call. And I want to thank everybody for listening.